Hi, my name is Alexander Fang. I'm a fifth-year pharmaceutical chemistry major.
Hello, my name is Charity Lee, and I'm a third year majoring in nutrition and foods.
Hello, my name is Diana Moua, and I am a fourth year majoring in biological sciences with a concentration in biomed.
Hi, my name is Molly Vang, and I'm a fourth year studying biochemistry and molecular biology.
Hi, my name is Zoua Vang, and I'm a fourth year human development major. And the title of our URC poster is Implementation of the Health Belief Model on the Hmong Population Online Health Education on Hypertension.
Our advisors are Kristen H. Bohringer and Christi Candido.
Hypertension is one of the most prevalent chronic health conditions in the United States. According to the Centers for Disease Control and Prevention, 45% of adults in the U.S. have hypertension, which is defined as having blood pressure readings of 130/80 or greater. The Hmong people are an ethnic minority group that immigrated to the United States approximately 40 years ago. Many Hmong individuals rely on their cultural beliefs to construct their health perceptions. The Hmong people mostly follow shamanism, and they have a distrust towards the allopathic approach of medicine. Galloway's health belief model recognizes perceived susceptibility as the strongest predictor for preventative health. With minimal knowledge of prevalent diseases, few Hmong individuals participate in accessible preventative services. A study on the adherence of hypertension care among Hmong Americans found that there is a need to address health misconceptions and promote adherence to medical care recommendations. The purpose of this study is to assess the Hmong's health perception of hypertension and their desired intentions or actions to prevent it. Our objective is to discern whether the health belief model is an effective method to guide the Hmong community to improve their perceived health susceptibility towards hypertension.
So, in order to measure the population's health perspective of hypertension, we conducted an online survey provided in both Hmong and English through Qualtrics from January 31st to February 8th. The survey was distributed by interns of Hlub Clinic worldwide via social media. We asked various demographic questions about sex, age, family income, education level, and many others. We created a short 5-minute hypertension education video in the respective chosen language, explaining what hypertension is, addressing its preventative measures, and providing positive lifestyle practices. This video was included in the survey with a pre and post 3-point Likert scale about the volunteer participants' personal health perspectives of hypertension. We modeled these questions after the health belief model to compare the perceived susceptibility to hypertension before and after exposure to our video. We then converted each individual score into a standardized 0 to 50-point scale and performed inferential statistics of the pre and post scores to identify the effectiveness of educational videos.
In our findings, we received 159 responses, 97 being of Hmong descent with an average age of 28. Based on our demographic questions, it showed that college was the highest level of education for 57% of the Hmong participants. We chose to display this demographic variable to signify that the majority of the participants were younger adults who may still be considered dependents. We also found that 82% of the participants were not filling out the survey on anyone's behalf. This variable identifies how the study was geared towards participants who knew how to use a computer or a smartphone to gain access to the online survey. And this exhibits how this channel choice may be the reason why our age average was so young. And based on these two variables, it shows how the online survey does not reflect the entire Hmong population, nor does it target the community members who may be at risk of hypertension. We also converted the 3-point Likert scale to a 50-point system and found the means of both pre-survey and post-survey point systems to be 40.98 and 43.61 respectively. We then performed a paired t-test and calculated the average differences. We found that the t-statistic was 3.21 and we found a p-value of 0.002. With that, we are 99.98 confident that the health education video significantly changed the participants' health perception about hypertension.
Despite their dependence on spirituality for health concerns, when given access to more consumable content, there is a significant increase of health perspective after exposure to a health educational video. Our research concludes that, to a degree, the health belief model is appropriate in improving Hmong community self-help perspectives for preventative action against hypertension. We understand the shortcomings of our research and are aware of improvements needed for our future works.
Going forward with our research, we hope to implement other models with the health belief model that suggests strategies for change and account for environmental context, along with a better channel choice for the more at-risk community members, such as attending community events. For effective delivery of health information, Hmong lifting underserved barrier interns will be properly trained in Hmong proficient lectures and activities for participants' long-term information retainment. We understand that our small sample size, young population, and data collection time does not accurately represent the entire Hmong population. We have also taken into consideration concerns of video viewing completion, with the average duration of survey responses varying from 8 to 9 minutes.
In addition, self-efficacy and the likelihood of successful behavioral changes towards preventive care was insufficiently assessed to definitively state that the health belief model is an effective model to improve the overall community's health perspective. To address this problem in the future, Hlub Clinic hopes to schedule follow-up appointments with participants during in-clinic visits in a span of 1 or 2 years after a health educational activity to measure quantitative health results insisting improvement. We at Hmong Lifting Underserved Barriers Clinic will continue to work towards improving the health perspectives of the Hmong community towards positive behavioral changes and taking action for proper preventive care while still valuing Hmong spiritual traditions. Acknowledgements. Hmong Lifting Underserved Barriers Clinic would like to thank the UC Davis School of Medicine, Dr. Christian Bohringer, and Dr. Ronald Jan for their support in helping Hlub Clinic attempt to improve the health of our Hmong community. We would also like to thank our participatory Hlub interns for their hard work in making this possible. Thank you for listening, and we hope that our poster presentation has given you a new insight, if not already, about the health belief model and its effectiveness in guiding the Hmong community to improve their perceived health accessibility towards hypertension. Thank you.